Good afternoon or good evening to everyone around the country, perhaps some other parts of the world. Really excited to spend the next hour or so with you talking about MACI for knee cartilage repair. I'm a sports medicine orthopedic surgeon. I'm on the advisory board of surgeons for MACI. Our other panelists here today are also paid consultants of Vericel. So I'd love to introduce this really special multidisciplinary panel. We have not only a surgeon, which is typical for a lot of these presentations at our meetings, but we're very fortunate to have Jessica Graziano, who is really an expert physical therapist on how we implement post-surgical care for our MACI patients. And so I think her insights, I always learn when I talk to Jessica, and I think you'll see as well that this is quite unique. And then if that's not enough, we have Courtney joining us today. Courtney is a pediatrician and also a MACI patient. So I think the dynamic interaction we're going to have between the three of us hopefully will give you a real well-rounded picture of what the power of MACI cartilage restoration for the right patients can do to change lives. And so we'll get things started here. I'm going to give just a very brief overview of MACI. Then Jessica will go through some rehab principles. We'll do a case presentation, and then we'll really save the bulk of the time for our discussion with Courtney and then questions and answers. So I don't know how experienced this entire group is, but we have a lot of people on the call. But just to kind of give this a 10,000-foot view, what we're dealing with is articular cartilage damage. And basically, cartilage is avascular. It has very limited regenerative capacity. So when you have injury, this sets off a whole cascade. It's kind of a vicious feedback cycle, disrupted proteoglycans, increased tissue hydration, collagen disorganization, and this essentially leads to injury progression. So what does that mean for the patient? It basically means pain, it means swelling, it means mechanical symptoms, it means inability to do the fun things they like to do, and it also sometimes means inability to do the things they need to do. And frankly, when left untreated, this may lead to osteoarthritis with its own trials and tribulations. There are a lot of treatment options out there for cartilage defects. It can get quite confusing for those of us who need to pick and choose. In general, they can be broken down into these three simple categories: palliation, repair, restoration. Palliation, quite simply, to get rid of pain, loose and mechanical flaps, so chondroplasty or debridement. Repair can be thought of like microfracture augmentation, or drilling. And we can talk about this in the Q&A, but really microfracture has fallen out of favor. Even though it's the most popular procedure for cartilage done around the world, it's the least popular procedure done by the experts in cartilage repair. But basically, it's not as durable of a regenerate, which is fibrocartilage, and it can degrade over time. And athletes may not get back to the highest level of performance versus other techniques. When we talk about restoration, that's really the wheelhouse for cartilage experts. For small defects, I think it's reasonable to consider things like oat autograft. There's likely a role for minced allograft. But when we're talking about large defects, when we're talking about defects of the patellofemoral joint, and we're talking about evidence-based medicine, we're really talking about autologous chondrocyte implantation, obviously the focus of this session, or osteochondral allograft transplantation. So what is MACI? It's very cool. It's really the first tissue-engineered autologous chondrocyte, or really cellular product that we have for cartilage restoration in America. So there were tremendous rigors with approval, and basically we take chondrocytes that are characterized, they're placed on a porcine membrane at a density of 500,000 to 1 million cells per centimeter squared, and then the surgeon's able to customize and implant this in the exact size and location correlating to the patient's lesions. For those in the audience who had to do first or second generation ACI, this is a way simplified version. It's really very expensive arts and crafts, which is why we'll spend most of the time on why we use MACI and just a little bit of the time on the technical details, which you can really pick up in a lab setting. MACI is less invasive than older techniques that are no longer existing for ACI. It's secured with fibrin glue, so long gone are the days of 6-0 Vicryl. It's quite versatile and flexible, conforms to most defects. There's uniform dosing of the cells on the MACI membrane. We actually get to know how the viability of the MACI and can tell our patients, which is quite an advantage. And most importantly, proven results, over 17 years of clinical experience outside of America, and FDA approved in America based on a very rigorous multi-center randomized controlled summit trial. What's the science behind it? So basically, pictures speak 1,000 words. The MACI membrane has a smooth side and a rough side. Essentially, the smooth side is a barrier so that the cells will be protected from the rest of the joint. And then the rough side, and you can see a blow-up of the rough side with these chondrocytes, basically is the side that is placed down onto the bony surface of the defect bed. And so you can see this cascade. Basically, the chondrocytes migrate from the membrane. They go through the fibrin glue layer, and then they begin to regenerate the patient's own cartilage. And so this is quite unique that you have your own cells making their own matrix to fill in potholes and to translate into improved outcome for the patient. So it's quite specific to that individual, which I think is unique from other techniques. So what defects are appropriate for MACI? We talk about this 2 centimeters squared. That's really like a 16 millimeter diameter if you're using a probe arthroscopically. So you can keep that in your mind. Bone depth, typically we can use MACI alone when it's less than 6 millimeters in depth. And so we can use our probe, which is about 5, put it into the defect bed to get a sense of whether it's too deep, and we'll require bone grafting of the bed, sandwich MACI type technique to get the job done. What's unique about third generation MACI is that it's not just indicated for the condyles or for the femur in general. It really has expanded indications, so medial lateral condyles, but also the patella and the trochlea. So this can help a lot more patients with significant knee pathology. So basically what we do in the operating room, this is a 2-stage procedure. The first stage, we assess the lesion to ensure that it is an appropriate candidate for MACI, similar to what we discussed in the last slide. If it is, then we take a biopsy specimen, so basically 2 tic-tac-sized biopsy specimens, usually from the intra-articular notch adjacent to the ACL. Those cells are sent to Vericel. They're expanded. They're uniformly seated on the 1,3 collagen membrane. And then they have very rigorous testing and assays to ensure that we are delivering exactly what we want to deliver back to our patient. And then we basically implant through mini arthrotomy with a fibrin sealant. And then we obviously, and most importantly, as Jessica will tell you, we need to adhere to fairly strict rehabilitation protocols to protect MACI as it remodels and to guide patients back to sport. One thing that's been a real game changer that I encourage you all to look at are these custom cutting guides. This used to be a fairly difficult procedure to really contour exactly with a foil template, come to the back table, cut it out, then cut the MACI. And really with these custom cutters, it's become very methodical and very simple to do, which is great. So essentially what we do in the operating room in the second stage through a limited arthrotomy, we just look in our set and we look at the appropriate size and shape of our defect bed. And then we use the custom cutter around the side of the defect. So we basically have just healthy remaining cartilage, gentle malleting around, and then just using a curette, getting down to but not through the subchondral bone layer. So we want to get through that calcified cartilage layer. And then we do the same thing on the back table. So the same size custom cutter. There's nice materials that are firm enough so that when we mallet, it detaches easily. And then we just pick it up, the MACI to the exact size with the pickups, making sure not to disrupt the cells. And we do minimal fibrin gluing in the base of the defect and around the edges. And then really, wait a couple of minutes for MACI to set. We test and range of motion in the operating room to make sure it doesn't delaminate, and knock on wood, even with large defects, and sometimes even a little bit unshouldered defects. I've not had one with just fiber and glue delaminate at time 0. That's okay if it did, though, because you have extra MACI and you can make sure that it's stable before you leave the OR. Here's just looking at that alternative technique that I mentioned, using foil templates, cutting around them, and then doing the same thing on the back table. You do still need to know how to do these types of strategies, particularly with odd-shaped defects, but the vast majority now can conform with the custom cutters. As I said, we apply fiber and glue, a very thin layer on the base, and then it's really just gentle thumb pressure, dabbing down the MACI. You do not want it to overhang the edges and pie crust, so you can contour the edges before, and if it's at all pie crusting, just use a scissor around the edges to make sure that it's sitting within the defect bed, protected by the healthy adjacent cartilage. And then we apply a little bit of fiber and glue to the periphery. And as I said, light digital pressure and then cycle to ensure a good range of motion. So at this point, after that overview, we'll jump to Jessica for a 10,000-foot view of rehabilitation, and then we'll come back for a surgical case. There you go, Jess.
All right, thank you. So I will be talking about the rehab following MACI. And as we can appreciate, given Dr. Sherman's presentation there, the impressiveness of the MACI procedure. And as he said, we want to make sure that during the rehab process, we protect the graft as it remodels. And with that said, we want to make sure that they get into the hands of the right therapist, so the right exercises are performed in order to not delaminate the graft. So a very specific physician-prescribed rehab program should be followed in order to foster early mobilization and load protection, while also promoting graft maturation and reducing the risk of graft delamination, preventing DVTs, and also preventing joint stiffness. These are all critical components to the success of the MACI procedure and for the individual. So any inability to cooperate with these prescribed guidelines is contraindicated in MACI use. The program itself is designed using the knowledge of basic science, the anatomy, the biomechanics of articular cartilage, as well as the natural course of healing. Rehab progressions are criterion-based. The guidelines do have timeframes attached to them to establish a guide, but it is more important to obtain the goals before actually progressing into each phase. Again, really understanding that each patient's recovery is unique and individualized and should be guided by the assessment of graft maturation, mental preparedness of the patient, physical strength, function, stability, and support. And we'll get a better appreciation of that with Courtney in the next couple of slides. So some key points of consideration here are, 1, patient adherence. We want to make sure that the patient understands on the first session of physical therapy the importance of range of motion limitations and weight-bearing limitations and how that affects the graft itself. When someone's not adhering to these guidelines, we will know secondary to abnormal effusion or pain. So we want to watch this and really reiterate the importance of following the guidelines for the patients and making sure they're adhering to these guidelines. Patient and or surgery-specific factors are extremely important. This pertains to lesion size and location, and this involves with how important it is to communicate with the surgeon in regards to all these aspects and will affect our rehab planning. Most of the time, the surgery-specific factors are written on the physical therapy prescriptions from the surgeons that we tend to work with. If not, it's very easy to give them a call, and we can get that information very easily. But that will significantly impact our rehab planning and the exercises we choose during the progress. Again, reiterating the importance of a criterion-based rehab progression, which focuses on achieving goals versus strict adherence to the time frame. We want to avoid excessive load and weight bearing, and we want to monitor and pain, swelling, and other potential mechanical symptoms such as locking of the knee. If we do see any of these abnormal signs or symptoms, we want to make sure that we, again, communicate with the surgeon right away. So in terms of considerations for defect factors, lesion size. clearly, the larger sized lesions will result in more exposure of the membrane to compressive and shear forces. This will impact our recovery because it may delay some of the weight bearing or range of motion limitations. Lesion location is extremely important for us as physical therapists. If the lesion is located on the patellofemoral joint, that's going to impact our range of motion progression throughout rehab. If the lesion is located on one of the weight-bearing surfaces to the femoral joint, then that's going to impact our weight-bearing progression. Duration of symptoms. If a patient has had pain for the past year or 2 years, we would expect them to present with some deconditioning. This also will impact potential apprehension in regards to therapy because of pain. So again, duration of symptoms is extremely important for us as physical therapists in terms of implanting a plan. Cartilage quality is important. General cartilage quality, normal versus chondropenia, all important in determining how the therapy progresses in terms of at a quicker pace or normal, slower pace. And again, remembering the individualized plan for each patient. Now, what's unique with this population too is most of the time we won't have someone come in with just a MACI procedure. There are concomitant injuries and procedures that can be performed. So you may get a patient that has an anatomical malalignment that's actually causing a lesion. So if the lesion itself is repaired and the anatomy isn't repaired, then the patient is actually just going to end up re-injuring again. So that's something we want to communicate with the surgeon to see if there were any other procedures performed during the surgery or if the patient had any other procedures performed prior to the surgery. So individualized factors to consider here. Patient age. Clearly, that'll affect the rate of the cartilage repair. If they're younger, they may repair a little quicker. Body mass index. Someone with a BMI of over 30, we may want to progress a little slower with the weight bearing because the amount of weight that'll be going through the weight bearing joints as well as through the lesion, depending on the location. Individualized goals are very important. This will impact the demands required of the repair tissue. So is your patient a runner? Are they a hiker? Are they a swimmer? Are they a tennis player? Do they play ice hockey? These are all different demands that are going to be required in terms of loading that tissue. Again, if someone doesn't want to run, we may not really need to progress them to running. But again, we want to make sure that we progress that tissue to the loads that it needs to withstand at the appropriate time frame so that when it does have to withstand those loads, it can. And that's all a part of the rehab process. Psychological considerations, this is extremely important. A lot of the times if patients have had pain for several months, several years before finally getting a repair, they may have fear of re-injury or a fear of self-efficacy. If this individual is an athlete and they're not able to participate in their sport, they may have a self-efficacy issue going on as well that we want to make sure we address. And constantly reassuring the patient that their progression in PT, we will adhere to the appropriate time frames, range of motion, and weight bearing, and that the graft will be fine. A lot of the times they see what was performed and they get nervous to move. So again, we want to make sure that we do reassure them during the rehab program. And knowing our patients, are they highly motivated? Will they follow exactly what we tell them, or will they tend to overdo things? Because again, overdoing things probably isn't the best thing early on during the MACI procedure because we want to make sure that they do adhere to the specific range of motion and weight-bearing limitations. And then also prior surgical history will be important because typically someone that's had multiple knee surgeries or any other surgery on that leg may have some quad atrophy or any other muscular atrophy on that leg, which again will slow down the rate of progression of their rehab program. So jumping into the rehab phases, this is all based on maturation of the graft itself, and timelines are based on the biology and do serve as a guide. So we have our 3 phases here: achieve routine, which is 0 to 3 months, which is more protective; our build strength, which is 3 to 6 months; our be active, and our 6 to 9 months. So in our first phase, achieve routine, is implantation and protection of the graft. The cells here are adhering to the bone and beginning to proliferate throughout the defect. In our second phase, it's transition and proliferation, and you've got the continued proliferation forming a defect spanning matrix. Our third phase is remodeling and maturing, to the expansion of the cell matrix into putty-like consistency and progressive hardening. until a durable repair tissue is formed. And again, as therapists, we want to make sure that we're providing adequate loading to the tissue, so again, it can withstand those loads later on. So diving into each phase a little more, into more detail, the achieve routine is our protective phase. So our functional goals here will be ambulation with crutches within the first week. We want to ensure full knee extension by 2 to 3 weeks. We don't want to have an issue with extension range of motion because that will impair gait. We want to make sure that they're following their weight-bearing precautions and that they have pain-free weight-bearing as needed. They should be independent with their home exercises as early as 1 month. And by the end of this phase, we want to make sure that they have full weight-bearing and full knee range of motion, which typically is about 8 to 12 weeks post-surgery. We want to make sure that progressing into the next phase, they're discontinuing the knee brace, and this is all dependent on their quad strength, their gait, and being pain-free with ambulation. Typical activity milestones that we anticipate during this phase, we do anticipate them starting to drive again and returning to office or seated work. They should return to light recreational activities such as walking. Again, this should all be pain-free. They should be able to perform activities of daily living such as navigating stairs, showering, etc. And this can start with the crutches and then progressing off of the crutches towards the end of this phase. So into the second phase here, building strength. So your functional goals here would be full and pain-free weight bearing and range of motion. They should have achieved this prior to progressing. We want to progress their strengthening exercises without pain or swelling. So again, no exercises should be pushed through. If at this point we anticipate them squatting or having pain with that, we don't just push through a squat or push through step-ups or step-downs. We want to make sure that the exercises are pain-free and we're not performing exercises just for the sake of performing them. They should be transitioned to a gym and a home-based rehab. As we know, with insurance, we tend to be limited sometimes on insurance visits. So their home program and their gym-based program is extremely important. They should be free from crutches. Some activity milestones that we do expect at this point, again, dependent on the individual's goals and the activities that they participate in, are returning to low-impact recreational activities, golf, cycling, yoga, Pilates, rowing, swimming, etc. They typically can return to more physically active jobs, such as nursing or construction at this point. Now, in our third phase, about 6 to 9 months during the remodeling phase, our functional goals are to increase the time, the distance, and the difficulty of exercises here, more functional. They should be able to tolerate lengthy or walking distances and return to a preoperative level of activity. Our anticipated milestones here will be increased running distances, skiing, snowboarding, weight training, and tennis. And again, reiterating that someone who's never snowboarded before probably shouldn't just pick it up during this phase to do so. We typically will see people return to work in those heavier labor fields, such as military deployment or firefighting. Now, 9 months and beyond is when we expect more sport activity dependence. And in terms of progressing to return to play or their sport, ice hockey, running, whatever it is, we want to make sure that we follow 3 specific guidelines here. So the patient's graft has to mature to the point at which it is able to withstand the specific needs of that chosen activity. The patient has to have been appropriately rehabbed at the point that they're able to physically perform those movement patterns and undertake the demands of the sport, physically as well as psychologically. And in doing that, we can provide the surgeon and doctors involved with return to play programs, so not just strength, but also their quality of movement is extremely important as well. People can run and jump, but how do they look when they run and jump? Again, we want to return them to their sport, but we don't want to see them again for another injury. So the quality of the movement is extremely important as well. The patient also has to have undergone an appropriate clinical assessment with the orthopedic surgeon experienced with the results of the MACI implant, and that is an extremely important point because they're ultimately going to be the ones that clear them. Now, in our last slide here, we really want to make sure that one of our take-homes with our therapists is that they do consider concomitant procedures. A lot of the times, our patients don't come in, again, with just a MACI procedure. other procedures can be performed, and we want to make sure that with those procedures that are performed, we're following the guidelines as well. So if a high tibial osteitis is performed, we want to make sure that we're aware of the limitations in terms of range of motion. A slightly increased range of motion progression may be implemented to avert loss of healing as well as radiographic healing. Distal realignment and ACL, typically they can progress to weight bearing right away and range of motion right away. But again, if a MACI is performed, we want to make sure that we know with the MACI procedure where the location of that lesion was, if it was the patellofemoral joint or the tib femoral joint. So all of these are extremely important with the progression as we see fit with the rehab program. And that really emphasizes the communication that we want to hold with the surgeons and all the doctors involved. So I'm going to throw that back to Dr. Sherman at this point.
Excellent. Thanks, Jess. And I encourage you all, please, text your questions, and we're going to have a lot of time for discussion at the end. I'm going to share my screen now, and we'll present a case. Wendy, if you want to have me share my screen, please. Jessica, can you see my screen?
Yep.
Perfect. So here's a patient of mine, a 17-year-old senior high school football athlete, had a non-contact patella dislocation with intra-articular loose bodies, presented to me with painful hemarthrosis, difficulty weight bearing. This patient's goals and expectations, which may be different than some, were really to return to the highest level of sport. When they first came to me after this quite big event, difficulty weight bearing, interestingly, when I was able to evaluate them, seeing them back in serial clinical examination, once the swelling went down, it looked like one leg was in more valgus than the other. The range of motion initially was difficult. These injuries, when they happen, non-contact, feel a pop, they're most likely ACLs, but like in this case, can also be patella dislocation. And in fact, I was able to get a good enough exam to see that the ACL was fine, and there was apprehension and guarding when I moved the kneecap around. So clearly noting the problem at the patellofemoral joint. What we can see here, we always get standard x-rays. So bilateral weight bearing, AP, PA flexion, lateral, merchant view, and for me in a salvage type practice, getting mechanical axis views from hip to ankle, always. So here I can see that there is a skeletally mature patient. They have no joint space narrowing. Looking at these merchant views, what you can see on the left involved knee is that there's some tilt and subluxation of the patella, which is different than the well-centered patella on the right knee. We can see this lateral view. You need to get a perfect lateral so that you can look at patella height, which in this case was okay. But what we can see here on a perfect lateral is this crossing sign, indicative of trochlear dysplasia, and this supratrochlear spur, again, indicative of a higher grade of trochlear dysplasia. This is the mechanical axis view. If you look at the right knee, you can see how the weight-bearing line goes directly central through the middle of the joint. Whereas if we look at the left knee, you can see that that weight-bearing line goes through the lateral compartment. MRI is a critical part of the workup. Here we can see bone bruises consistent with patella dislocation. Every dislocation, for the most part, has a disruption of the medial patellofemoral ligament. We can see here there's a central cartilage defect on the weight-bearing zone of the patella. We can see a loose body in the gutter. We can see a very flat kneecap groove, and the tibial tubercle trochlear groove distance is 14, which is normal. That's a measure of lateral maltracking. We also see a smaller cartilage defect over the weight-bearing zone of the lateral femoral condyle. Having seen enough of these and reading the literature, we know that MRI can underestimate the size of cartilage defects. So if we see something like this, it's possibly quite relevant and quite central, especially in a young patient. You can see the defect here with the underlying bony edema from the recent injury. Patella height on this MRI is normal. I like to check things in two places. So now we have X-ray and MRI confirming patella height. Here's our arthroscopy, which was indicated because of the loose bodies. You can see this is what perfect cartilage, perfect meniscus looks like. We can see in the lateral compartment, I'm removing fragments of cartilage only. So there's no bone on this cartilage, and you can see how it's in multiple pieces. Those two factors do not bode well for trying to put this cartilage back in place and have it heal and provide meaningful change for the patient. So to me, these pieces were unfortunately irreparable. You can see the defect in the weight-bearing zone. Here's my probe. This wound up being 2.5 centimeters squared of the lateral femoral condyle. And then we can see going into the medial gutter, retrieving the other piece of bone of cartilage, hoping there's bone on it, but unfortunately, this is the recipient bed on the patella. So another quite large weight-bearing defect on the patella, 2.8 centimeters squared. And so it was not salvageable. And so now that the loose bodies are gone, at the time of this index arthroscopy, I can understand and think about what I might have to do for this very young, very active patient with malalignment, multiple cartilage defects, and a very high demand. And so for me, I like an ace in the hole. I take a biopsy for future MACI. Here you can see why I talked about the 2 tic-tac size specimen taken from the notch with a gouge or a curette. I always, for the surgeons out there, I always make a problem list. I put it in my op report at the end, my future plan. So here's my problem list: asymmetric valgus, trochlear dysplasia, laxity of the medial patellofemoral complex, lateral retinaculum tightness, and then these 2 medium to large size cartilage defects of the patella and the lateral femoral condyle. And then I make a surgical plan. So for me, I felt for this young person, we had to treat it all. You really have to optimize the joint environment for cartilage restoration. You can't just go right to the cartilage or things will fail. You have to fix alignment if it's abnormal. You have to balance the soft tissue. So for me, that's a distal femoral osteotomy to correct valgus, MPFL and lateral retinaculum lengthening to balance the soft tissues, and MACI to the patella and lateral femoral condyle. Here we can see the distal femoral osteotomy. So I would say while some procedures we do with MACI do not require concomitant unloading, the vast majority, and particularly in salvage, with patients who come with multiple prior surgeries, they likely need either DFO, HTO, TTOs, or some other types of osteotomy. So if you're going to do this work, you should be facile with osteotomy. Here's looking at the patella MACI, so quite a large portion of that patella, and the MACI in the lateral femoral condyle defect bed. Basically for this one, rehab, toe touch weight bearing with crutches for 6 weeks, progression, range of motion. I like to use gravity assistance, but also CPM. We could talk about blood flow restriction, TENS, cryotherapy, things that I think can be value added with these patients in that first period of protection. And then we progress to Jessica's phase 2, in that 3-month range, resuming low impact activities, 3 to 6 months. For this one, which is more complex, the time frames may be pushed back versus an isolated MACI of the condyle or trochlea. So linear activities at 12 months, and then moving into the more B-active impact activities greater than 15 months. But the key point is time and criteria-based rehabilitation, as has been stated before. Here's the kid at 6 months. You can see excellent quad activation, really good range of motion, well-healed incisions. We can watch him walk. He has a normal gait. He has normal double limb squat. We can see how he single limb squats. We can see how he steps up, steps down. And so we can use these clinical criteria matched with our therapist, more rigorous measurements to really guide progression. Here we can see he's not too tight, which is very important. The enemy of good is too tight in any of these cases, particularly combined osteotomy, soft tissue, and cartilage. So he had good 2-quadrant translation of his medial patellofemoral ligament and lateral retinaculum. Here you can see x-rays and most importantly that weight-bearing mechanical axis, which is now right down the middle on the far part of your screen. I like to get MRIs when I can. You can see the regenerate cartilage both in the patella and also over the lateral femoral condyle. We do outcome scores for everybody. I need to track how patients are doing. We need to report on these outcomes. So I encourage you to try to be able to do that if you can. You can see at 1 year, this patient was doing extremely well compared to baseline. But when we start teasing out things like sports, recreation, Tegner scores, etc., there's still a reasonable way to go. And I think that's somewhat conservative rehab for a big case. and somewhat because it just takes, frankly, a long time for these patients to get back to feeling quote-unquote normal, or being able to return to the things that they love to do. So hopefully that all showed up quite well. I'm going to stop screen sharing, and think everybody is back online here. I think for the next 15, 20 minutes or so, we're going to really have a nice interactive discussion with Courtney. As I said, Courtney is a pediatrician. She is a MACI patient. She is not my MACI patient, so I can't take credit for her good outcome or any of the successes that she might talk to you about. But it certainly will be a very dynamic and interesting discussion. So I guess to start this off, Courtney, maybe you can kind of just bring the audience up to speed on your initial injury and kind of what happened subsequently after that.
Sure. So I tore my ACL while I was in high school playing field hockey. I was 16 at the time, and I had my surgery after that for reconstruction, and I did pretty well. I went off to college. I was fine. I started running in college just since I wasn't doing all the sports that I had been doing in high school. So I ran for those 4 years, then I went to med school. I was fairly active. I used to work out a lot, and I used to run quite a bit, both competitively and, just for exercise. So that 8-year period, I was great. I didn't have any knee pain. And then I started my residency after that, and it was those first few months when I started having just some kind of dull, achy pain initially, just with running and with exercise.
Mm-hmm. And so, as you were in your residency, going from running, which you love to do, did anything change, or did it progressively get worse so that it might have affected things that you need to do, not just things that you want to do?
Sure. Yeah. Initially, in the beginning, it was just with exercise. And it was pretty progressive. Like, at least initially I cut back on the length of my runs and the frequency, and then I pretty much stopped working out altogether over a period of a few months, which kept it at bay for just a short period of time. Then I started having a lot of pain when I was at work. It progressed to the point when I could barely walk up and down the stairs at the hospital, and even just being, working like 10, 12, plus hour shifts. I was having so much pain, so much swelling. So that was probably over the period of like a year and a half.
Did you have any mechanical symptoms at that time, like true catching or locking, or would that have driven you perhaps to, seek treatment a little bit sooner?
I was having some locking. It was pretty infrequent though. I remember like 2 or 3 specific times when my knee locked and it was just like extraordinarily painful. And I think after like that second or third time, I was like, this is like, something's wrong. Like I can't, I can't be at work and not be able to move, or need to, take a few minutes where I have to like sit down and like immobilize. So yeah, I think just with that, and then obviously the progression of symptoms, then it was time to, figure out what was going on.
Yeah, I think, certainly we see a lot that the locking, symptoms drive people earlier, but as you alluded to, painful effusions and swelling can shut down your muscles and, can lead to significant dysfunction and pain as well. So it sounds like you were having a good amount of problems with your knee. I guess, what were the things that, why did you decide to, now's the time? I know you kind of alluded to it with the locking, but, what really was the final straw that broke the camel's back there for you?
I think I remember just not even being able to go up and down the stairs. And at the time I had stairs in my apartment, and just every morning it was just this constant reminder of like, just this pain that, started first thing in the morning, lasted all day. And and then so once I realized that it pretty much started, impacting my quality of life pretty significantly, that was when I decided. But also, I mean, people were seeing me at work and, knowing that something was wrong. So it was actually like some of my colleagues had recommended that I should go see someone in sports medicine.
Yeah, I think you paint a great picture for the audience, who may be seeing patients like you, that you're a quote-unquote cartilage patient. I mean, you have pain, swelling, mechanical symptoms, pain that's not just for running, but also daily life and maybe even sometimes at night. Levels may be higher than 6 out of 10, and a percent normal, that's, that's really bad. So you finally went to see orthopedic surgeon. You had a workup probably similar to what I showed in my slides with x-rays, MRI. So how'd the discussion go, or what do you kind of take from that initial encounter? What were you told about your knee?
Sure. So so exactly like you said, so I had an x-ray. I saw someone, I think it was a family medicine practitioner in sports medicine first. He did an x-ray, did an MRI. Once he saw my MRI findings, then he referred me over to ortho. And I guess kind of going into this, my biggest concern was that I wasn't even necessarily thinking about a cartilage problem. I was worried that I had damaged my ACL graft in some way. And was worried about what that would mean for future surgery while I was in my training. But I talked to my surgeon, and he said, we're going to have to do an arthroscopy just to kind of see what's going on and, confirm, what we're seeing on the MRI. And at that point, we had talked a little bit about the cadaver transplant, I think, going into that first surgery. But I didn't hear about MACI until after I had that first arthroscopy.
Mm-hmm. Was your ACL intact or was not intact?
I had, correct me if I'm wrong, I think, is it called a cyclops lesion, where I think some of it is it's torn? Yeah. So I had that cyclops lesion. I think I also had some meniscal damage as well. So all of that was taken care of during that first arthroscopy. And then he also obviously noted that I had full thickness cartilage loss on my femur as well.
And was that where they took the biopsy for MACI during that arthroscopy?
So it wasn't during the first one. After that first surgery, we talked a little bit more about, again, the cadaver transplant is an option. And then after that initial visit was when we started talking about MACI a little bit more. And once I decided that I was going to move forward with MACI, then I went ahead and we did a second quick procedure just to do the biopsy.
Mm-hmm. Yeah, and I think in these types of challenging scenarios, it's not uncommon to have, a couple of arthroscopy and staging arthroscopy in particular. The joint is an organ, as you know, and we really need to understand how was your ACL, what's going on with the meniscus, fixing and or thinking about the alignment, and obviously paying attention to your full thickness, femur cartilage defect. And so I guess to you, what were like the key things once you really decided to go forward with MACI that drove you towards that specific procedure versus, let's say, osteochondral allograft transplantation, the other procedure that may be utilized for these large focal defects?
I was most interested in MACI because if just from like a practical, like logistical perspective, it was really important for me to be able to schedule my surgery ahead of time. Obviously with the cadaver option, I was kind of cautioned, you'll go on a list and we'll call you when we have a tissue match. And that at that time in my life, I was in residency and I wanted to minimize taking time off and having to like disrupt my entire schedule. So that was just from a practical perspective, that was really important to me. And then, of course, even taking a step back from that, my surgeon reassured me. I wanted to make sure that, this was a good option and that, that it was a comparable option to, the cadaver transplant. And so once I got that reassurance from him and then I did my own research, that combined with the flexibility of scheduling was really what helped to solidify my decision.
Yeah, I think those are all great points that you brought up. I think, for our patients out there, some don't want cadaver parts. So having your own, tissue, really growing your own cells and your own matrix does sound appealing. Your own time frame, that's a huge thing that comes up with my patients, particularly some that travel from far away. And I think it might be something in this crisis that we might be able to strategize and plan more than some other techniques. And I think one other concept that is appealing to me, at least, if I were thinking about these, is that it's a surface procedure, so it's not burning bridges. I mean, your knee, when you have an ACL tear, it's something that sets a cascade towards potentially, osteoarthritis over your lifetime. And so these types of procedures you're doing in your 20s, don't burn bridges for anything that you hopefully won't need, but may need in your 30s, 40s, and beyond. So I think those, to me, are big points. And then, one thing I'd like to ask you about, because we get this a lot, after the staging scope biopsy, did you feel any better? And, some people actually do feel better, at least for a while, and maybe try to put it off. Or did you know once you regained your muscle strength and recovery that it didn't make any difference to you?
I felt better, for a short period of time. I immediately after surgery, I actually had a lot of pain, much more so than I was expecting to have. And I don't know if that's because, things were kind of cleaned up in the knee at that point. But I felt better maybe for a few weeks. But my range of motion still was not right, and it was only a matter of like a month or two before I went back to having a lot of the same pains, with weight bearing and going up and down the stairs that I was having before surgery.
And we're going to pivot over to the rehab portion of this with Jessica asking you some questions in a moment. But before we do that, I think it's really important with MACI and cartilage restoration or joint preservation in general to really talk to our patients. It's not just a single quick visit. It's an hour discussion, probably multiple times, and re-emphasizing expectations. So I think, can you hit on kind of the expectations that you remember your surgeon talking to you about regarding activities and about the rehab time frame, and then Jessica will pick up with some specifics on the actual rehab.
Mm-hmm. Yeah, I remember when my surgeon was telling me about these two options, he was very clear that the rehab process looked different for both of them, and particularly for MACI, that it was very structured. I might have limitations that, for example, even if I felt like I could do a certain activity, I might not technically, I wouldn't be permitted to do it, or it wouldn't be recommended to do it so that my graft could heal. So that was made very clear, going, in anticipation of my surgery. And I had actually been seeing my physical therapist probably for about 6 months before I had my MACI. So I talked to her about that a lot as well. And so, again, you don't really know what to expect until you're after surgery. But I did have, that was a very clear expectation that was set. And me, I wanted to make sure that I had the best chance of success of the graft and, not having to have another surgery in a year. So I took that to heart, and that was part of my my decision process.
And I'm not sure if Jessica does, but I sometimes use those pictures that we showed as far as the phases of remodeling. And, as a reminder to patients, even if you feel good, this thing is still not as durable as the final product yet. So we need to go slow to go fast is something I love to tell them. But go ahead, Jessica.
Mm-hmm.
Yeah, and Courtney, thank you so much for sharing your experience with us and everything. I really appreciate it, and I'm sure everybody on the call appreciates it as well. So if you could just share for us, maybe your experience that first week. I know individuals, we tend to have different results. They vary across population, but what was your first week like after surgery?
I actually felt pretty good after MACI. I feel like I actually had more pain after that very first arthroscopy. When I came home from MACI, of course I had, that post-op pain for the first day or two, but I felt really good, and I felt like I could walk on it and I could weight bear. Obviously I had that full leg brace on, and I needed that. Like I was in that at all times. But with my leg brace, like I felt like I could weight bear. And obviously I was using my crutches. But I was pretty surprised at just, even within just like a few days afterwards, how good everything felt. And then I probably waited, it was right after I like had my stitches taken out after my first post-op check that I got the clearance to go back to at least see my PT. And then I started doing that flexion machine at home as well, maybe in like a week or two, I think, after surgery.
Okay, so you started your physical therapy about a week?
Maybe it was closer to 2 weeks. It was right after I had that first post-op check with my surgeon. So I think maybe probably closer to like 2 weeks.
And what activities did you start with in physical therapy?
In therapy, it was pretty. There wasn't very much in the beginning. I think as far as I remember, so something I did have trouble with, I think, over the first month, even maybe the first 6 weeks, was I had a lot of quad atrophy after surgery, which I wasn't expecting, and which I didn't remember from, my prior ACL surgery rehab that I had in high school. So a lot of it was like stimulation and just working on kind of regaining my quad strength. And then in a few weeks, I even got on the bicycle in PT, and I started just doing like half revolutions, like on the bicycle, and then worked my way up as my range of motion was increasing to like full revolution cycles.
Okay. And about how long after surgery did you start driving and return to work?
I started driving probably a month after surgery. Maybe a little bit sooner. It mostly just because it's a little logistically hard. My surgery was on my left side, and I had that full knee extender brace on for 6 weeks after surgery. So just kind of getting in and out of a car with that's a little tricky. And then also, like I said, I had pretty significant quad atrophy, so I needed to kind of move my leg quite a bit. With my arms. But yeah, so I started driving maybe a month after. And then I actually went back to work around that time as well, with crutches and with my knee brace on.
And how did you feel at work? I'm sure everybody was happy to have you back.
Yeah, it was good. I was I was still in residency. I set up my schedule, so I was on like pretty light, like outpatient rotation. So I wasn't, obviously doing like overnight shifts and inpatient, like longer rotations. But it was kind of like a gradual return to work. But it felt really good to be back after being at home for those first few weeks.
Mm-hmm. And in terms of the activities that you enjoyed doing before the knee pain, when were you able to return to those activities?
I started, so prior to surgery, I was doing a lot of cycling classes. I probably started doing those maybe like about 4 months after surgery, and it not like aggressive, classes, but I started going back to that maybe like 4 months or so. And then even just like kind of low incline hikes, like in LA, like I was doing that probably about like 3.5 months. And then about 6 months or so, I started running outside a little bit, and certainly I was, at the gym, on the elliptical much sooner than that.
Okay. That's great. And then did you have any challenges that you felt like you faced during the rehab or after rehab?
I think, so like I mentioned, I think the biggest challenge was getting my quad to start working again. Because I could walk, like I could weight bear, I could walk, but I was cautioned, like I have to be in that knee extender or that brace just until my quad starts working again, just to protect my leg, I guess. So that was a little bit tough, and it took probably about like 5 to 6 weeks. I actually ended up needing, I had like a home like muscle stim machine that my surgeon had had ordered for me just to kind of help. That was probably the biggest setback and frustration, but again, after 6 weeks, I started walking, I got rid of my crutches, and then after that, I think therapy started progressing pretty well. I was on the anti-gravity treadmill at PT, and then I was also doing blood flow restriction as well.
Awesome. Yeah, the blood flow restriction has really demonstrated some great results. And then are there any takeaway messages that you would want to let someone know that was potentially getting a MACI procedure that you think would be helpful before the procedure?
I think the biggest thing is just about kind of going back to the rehab process, just because, exactly everything you guys are saying, like it is a very structured rehab. And I think that it's just, if you want to kind of optimize your chances of success and the surgery working for you, I think that's the one thing that I usually tell people. And I saw people when I was in PT who had the cadaver surgery and were doing a lot more than I was doing at my point. And, that can be a little frustrating, I think, especially because a lot of other patients that I was meeting at the time, they're like, what surgery did you have? And they had never heard of MACI, so that's the one thing that I usually, that I kind of tell patients who are considering, just so that they're aware of it, because it can affect your life after surgery and, the amount of time it takes to kind of get back to, to normal life afterwards.
Mm-hmm.
And so, Courtney, you're here now. How far out from your MACI implant?
I'm about 2.5 years out now.
And so how would you say you're doing?
I'm doing great. I can do everything that I want to do. I can work without pain. I can go up and down the stairs. Like everything that I want to do, I can do. And yeah, I'm thankful. And if I had to have another knee surgery again on the other side, I would definitely do MACI again.
Yeah, I think that's a great question that I always ask patients at this phase. Is when I know they're doing well, what do you want to do that you're not doing? And if the answer is nothing, which it can be some of the time with patients with good expectations, I think that's awesome. So that's really exciting for you. And I think just a really good testament to, your doctor, patient, therapist relationship and getting you through in a really busy part of your life. So that's outstanding. One more thing, we have a couple of great questions and a few more minutes left. Thanks so much to Courtney, and if you want to chime in with any answers to any of the questions, obviously you're welcome to participate. If the audience is really hungry for more, my good friend from The Ohio State, David Flanagan, is doing a webinar on May 28th. He's going to be talking about lesion progression, so a little more in the weeds than this high-level overview, and then really special panel discussion. So I'm going to look at a couple of the questions here. And then if they're physical therapy question, or if Courtney wants to chime in, that would be great. How aggressive are you using MACI for medial patella lesions when addressing patellofemoral instability? So I guess that's a surgeon question. Thanks for asking it. I'm not that aggressive, I think, is the short of it. If these are very distal, medial, maybe even not necessarily weight-bearing part of the patella, then you might debride a little loose fragments and then go from there. If they're larger, they cross the midline, then I think they're relevant defects. They can be associated between these dislocation episodes with painful effusions, mechanical symptoms, not just pain with the episodes may drive me to treat. But in general, some of them are small and off to the side and don't need aggressive treatment. That said, if you're on the fence about whether it's big or relevant, always take a MACI biopsy. We're most of the days trying to biopsy to implant, meaning picking patients like Courtney who want a two-stage solution and executing, not waiting and seeing how they're doing. But I think that it's not wrong to have the ace in the hole just in case you might need it. Let's see. What are your thoughts or education to your patients when they present with a cartilage defect? As we know, cartilage does not repair itself and can further degenerate. What are the thoughts, or what would you say to a surgeon that tells a patient, let's see how you do, versus being a bit more proactive and confidently moving forward to restore a patient's defect? Thanks for that question. I think that we need to respect that we can do some harm here, and that we really want to pick our cartilage restoration patients wisely. It depends on who the patient is. If they're the young athlete I showed with high demand levels and expectations and big focal defects in their weight-bearing zone, how are they going to do in a couple of years, 2 to 5, 10 years without treatment with malalignment? Probably terrible. If they're a middle-aged person, they have a little bit of pain, they haven't rehabbed, they have some minor discomforts. Am I going to put them through, potentially big, or morbid, two-stage type situation? So, we don't know everything about the natural history of all these situations. We can make people worse, so we want to choose the right patients, patients similar to what Courtney described. And then, obviously, when you have good rapport, a patient who needs salvage surgery or young person with big defects, go for it and plan together and set the expectations and execute. So I think there's a balance between different patient types. Here is a question for Jessica. What's your typical rehab for patella MACI in conjunction with a tibial tubercle osteotomy? So I guess weight bearing and range of motion.
Yes, that's a great question. And again, with the TTOs, we know that is going to affect our weight bearing, right? And then a patella MACI is going to affect our range of motion. So with the osteotomies, typically and this is where you're going to want to, as a therapist, talk with a surgeon, because everybody's guidelines will be somewhat different depending on exactly what they do. But typically with the TTOs, their weight bearing is about foot flat to maybe toe touch the first 6 weeks. So we want to make sure that we're going to follow that. And then in terms of range of motion for patella, you can do about 20 to 30 degrees. And typically with the TTOs, they may have a CPM as well. Dr. Sherman, for your TTOs, do you typically refer them to have a CPM early on?
Yeah, I do typically use CPMs for isolated TTOs and for TTOs combined with MACI. I just want to, with the MACI, obviously protect it, as you said, so I'm not as aggressive with the range of motion early. TTOs typically, particularly if you're going to have to distalize, can be a little less hinged. You just want to protect that a little more while it heals early. So I might continue with my weight-bearing restriction a little longer, or my brace a little longer with distalization versus an anteromedialization where I have that green stick. So some intraoperative factors to communicate to the therapist that can help you kind of help me and the patient. One thing maybe I can get Jessica to comment on, there's MACI can get complex as far as concomitant procedures, but we can keep it simple. We're only able to go as fast as the most conservative part of your protocol. Would you kind of agree with that? So if you kind of stack up 3 to 5 different procedures, you look at what the weight-bearing restriction of the most conservative one is and what the range of motion restriction of the most conservative one is, and then you can mix and match with the variety of size, shapes of defects, osteotomies, and soft tissue balancing. I wonder if you have any comments.
Very well said, Dr. Sherman.
This is from Allison. Good. Do we get post-op MRI after MACI, and if so, when do you get it? I try to get MRIs on everybody. I'm collecting data. I want to report on it, so it sometimes is limited by insurance. But if I get it, I'll get it at a year and try to get it at 2 years. Let me throw this to Jessica. Do you or anyone that you work with use MRI criteria to help with releasing people to activity, return to activities in sport?
Yeah, typically our progression here with the surgeons that we work with, when they're ready for return to play assessment, we'll do that, and we're constantly assessing functional progression throughout. And again, it's pending how the patient feels, they're strength-based. The physician will definitely not clear them until we have that. And so that's going to indicate, I'm sure, maturation too. So we like to see the MRIs. I know as a therapist, I like to see imaging to see what's actually going on. So I think you alluded to a great point early on when you said you like to show the patient what the graph looks like, because sometimes they can feel great, but they don't know what's going on internally. So it's always great to have the image available, and I think that's another tool that the surgeons can use in terms of not just the strength gains, but also the return to play quality of movement patterns, and then, of course, the MRI after the knee procedure.
Courtney, did you have an MRI after yours?
Yeah, I had one a year after my surgery.
You did. Good. Yeah. So, I think it's a good thing to get. Before I get an MRI, I always, lay crepe as far as a grain of salt. If it looks wonderful and the patient's not doing well, then we got more work to do. If it looks terrible and they're doing well, then, what are we going to do with it? I think, when it looks great and they're doing great, that's amazing. So I think the patient knowing those 3 routes before you get any imaging studies so they don't freak out, and alerting your radiologist so that they know that it was a MACI and it's not going to look perfect, yet. But when I actually like when they don't know it's a MACI and it looks almost as good as normal cartilage, it fools them. That's always a good one. So let me see. Do we have one last question? For trochlea or patella lesions, do you ever do straight anterization when compared to AMZ? And if so, you got me with 2 different question boxes along with the AMZ. I think that when you're doing cell-based cartilage restoration, we get better outcomes in general with osteotomy, particularly for the patellofemoral joint. And so I'm very quick to do a realignment. If medialization does nothing, for offloading cartilage, so an anteromedialization could offload. And frankly, if I have a defect and no height abnormality or lateral maltracking, I'll do an anterization in isolation for those patients along with my MACI. I would definitely add that for bipolar patellofemoral lesions on both sides of the joint, just to globally reduce those joint pressures, and I think that it improves outcome. So hopefully that answered the majority of questions. I can speak for, I think, Jessica and the Vericel team. We love this stuff, so we're happy to kind of, take any questions that might come to Carla and the rest of the crew after the fact. And really appreciate Courtney sharing with us. It takes a lot to kind of go from the doctor to the patient and really give us these key insights. So I always learn when I chat with you. And everybody have a great evening.
Indication for use. MACI, autologous cultured chondrocytes on porcine collagen membrane, is an autologous cellularized scaffold product that is indicated for the repair of single or multiple symptomatic full-thickness cartilage defects of the adult knee with or without bone involvement. MACI is intended for autologous use and must only be administered to the patient for whom it was manufactured. The implantation of MACI is to be performed via an arthrotomy to the knee joint under sterile conditions. The amount of MACI administered is dependent upon the size, surface in centimeters squared, of the cartilage defect. The implantation membrane is trimmed by the treating surgeon to the size and shape of the defect to ensure the damaged area is completely covered and implanted cell side down. Limitations of use. Effectiveness of MACI in joints other than the knee has not been established. Safety and effectiveness of MACI in patients over the age of 55 years have not been established. Important safety information. MACI is contraindicated in patients with a known history of hypersensitivity to gentamicin, other aminoglycosides, or products of porcine or bovine origin. MACI is also contraindicated for patients with severe osteoarthritis of the knee, inflammatory arthritis, inflammatory joint disease, or uncorrected congenital blood coagulation disorders. MACI is also not indicated for use in patients who have undergone prior knee surgery in the past 6 months, excluding surgery to procure a biopsy or a concomitant procedure to prepare the knee for a MACI implant. MACI is contraindicated in patients who are unable to follow a physician-prescribed post-surgical rehabilitation program. The safety of MACI in patients with malignancy in the area of cartilage biopsy or implant is unknown. Expansion of present malignant or dysplastic cells during the culturing process or implantation is possible. Patients undergoing procedures associated with MACI are not routinely tested for transmissible infectious diseases. A cartilage biopsy and MACI implant may carry the risk of transmitting infectious diseases to healthcare providers handling the tissue. Universal precautions should be employed when handling the biopsy samples and the MACI product. Final sterility test results are not available at the time of shipping. In the case of positive sterility results, healthcare provider or providers will be contacted. To create a favourable environment for healing, concomitant pathologies that include meniscal pathology, cruciate ligament instability, and joint misalignment must be addressed prior to or concurrent with the implantation of MACI. Local treatment guidelines regarding the use of thromboprophylaxis and antibiotic prophylaxis around orthopedic surgery should be followed. Use in patients with local inflammations or active infections in the bone, joint, and surrounding soft tissue should be temporarily deferred until documented recovery. The MACI implant is not recommended during pregnancy. For implantations post-pregnancy, the safety of breastfeeding to infant has not been determined. Use of MACI in pediatric patients younger than 18 years of age or patients over 65 years of age has not been established. The most frequently occurring adverse reactions reported for MACI greater than 5% were arthralgia, tendinitis, back pain, joint swelling, and joint effusion. Serious adverse reactions reported for MACI were arthralgia, cartilage injury, meniscus injury, treatment failure, and osteoarthritis. For more information or to view full prescribing information, please go to maci.com.